Hello everyone, in this section we'll be covering substance-related disorders. So when substance use disorders or diagnosis is discussed, these are the areas or substances that are referred to and that they each have a different code in the DSM for each substance. And also, while I'm not going to read these, I wanted to point out this final one with gambling. Although it's not a substance, it is included in substance use disorders. So according to the most recent version of the DSM, substance use disorders are defined as a problematic pattern of use leading to clinically significant impairment or distress as manifested by at least two of the following occurring within a 12-month period. Now we're going to get into the criteria of substance use disorder, and there are 11 in total, and they're split up into these sections just so that you have a better understanding of the nuance of each symptom or criteria. And even though they're split up this way, remember a client can meet two across any of the sections and still meet the qualifications to be diagnosed with substance use disorder. So the first section we'll be looking at are the criteria that look at impaired control. So number one, substance is often taken or used in larger amounts or over a longer period than was intended. Number two, there is a persistent desire or unsuccessful efforts to cut down or control use. So someone has made an intentional effort to use less and they have been unsuccessful of that, whether that's tapering the amount, whether that's using for a fewer amount of days, or I'll only use or drink on the weekends or anything like that, and they're not successful at it, that will qualify as an unsuccessful effort to cut down or control the use. Number three, a great deal of time is spent in activities necessary to obtain, use, or recover from effects of substance. And so in the substance use community, it is fairly common for this to be referred to as the mental obsession, meaning what am I going to do to get this substance? Number four, craving or a strong desire or urge to use the substance. So our next set of criteria looks at social impairment. So these are the criteria that have a negative impact on social interactions with people and relationships with others. So number five, recurrent use resulting in a failure to fulfill major role obligations at work, school, or home. So maybe you were dependent before or had certain expectations before, but as a direct cause of your use, you're unable to meet those commitments or obligations. Number six, continued use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of substance. So at this point, the use has become so invasive that it is directly impairing your social relationships to a noticeable effect, even sometimes by an outsider. And you still continue to use despite you knowing that it has this impact. Number seven, important social, occupational, or recreational activities are given up or reduced because of substance use. So giving up hobbies, things that you enjoy, because substance use has taken priority over those things for you. So the next set of criteria looks at risky use of the substance. So this is going to be any substance use which could potentially put you or someone else in direct harm. So number eight, recurrent use in situations in which it is physically hazardous. So maybe you have a job where you have to climb a scaffold or something like that, and you're still using while on that job, or maybe using while driving, or maybe operating heavy machinery under the influence of that substance, and knowing this prior to engaging in the substance use. Number nine, use is continued despite having knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by substance. So maybe someone is aware that they have a physical or mental condition that they know is exacerbated by use. So for example, someone who has something like schizophrenia or a psychotic disorder that is known and they are informed that substance use either for example interacts with medication or otherwise exacerbates symptoms, and they know that this is going to happen but they engage in substance use anyway. That's considered a risky use of the substance as well. So the last set of criteria for substance use disorder is going to be the pharmacological criteria. This looks at the physical symptoms of substance use. So number 10, tolerance as defined by either of the following: a need for markedly increased amounts of substance to increase intoxication or desired effect, or a markedly diminished effect with continued use of the same amount of substance. So basically, the body has built up a tolerance in such a way that you need more of it to achieve the desired effect. And number 11, withdrawal as manifested by either of the following: experiencing withdrawal symptoms in absence of the substance, or substance used to relieve or avoid withdrawal symptoms. And with either of these, tolerance or withdrawal, a lot of clients with substance use disorder or substance use issues might report that they use not even to feel the effects of the substance anymore, but just to feel normal because they've become dependent on that in a physical way. So now we're going to briefly talk about severity and specifiers, and these two things help us better understand what substance use disorder means in the context of that individual, and it just provides really important nuance to help us understand what's going on for the individual a bit better. So starting with severity, a substance use disorder is considered mild if 2 to 3 criteria are met. It's considered moderate if 4 to 5 criteria are met, and it's considered severe if 6 or more criteria are met. And as far as the specifiers go, you can have an early remission. This is when someone is in those beginning recovery or treatment efforts from substance use disorders, and they've maintained some semblance of abstinence from the substance, but for a fairly short period of time. There's also in sustained remission, and this is when the individual is able to, typically on their own or with support, less invasive support, so something that's not like an inpatient treatment program or something, and they're able to maintain abstinence from the substance use for a prolonged period of time. And the next one is on maintenance therapy, and this one speaks to anyone who's typically prescribed a medication that helps taper their substance use, and so they haven't met the substance use criteria for this, the substance use disorder criteria for that prescription. So for example, methadone, things like Suboxone are common things used to treat opioid use disorders. However, some people can present with a substance use disorder that is methadone or Suboxone. So even though those things are prescribed by physicians, by professionals to help taper substance use of particularly as it pertains to opioid use disorder, people can develop or prefer those medications and develop a substance use disorders for those medications. The only exception to this is tolerance or withdrawal, because you can experience the tolerance or withdrawal symptoms, not necessarily both, because remember, meeting 2 criteria, you'll qualify for substance use disorder. So someone can experience the tolerance or withdrawal for a medication prescribed for maintenance therapy without meeting the criteria for substance use disorder. And so again, it only counts as maintenance therapy if the person does not meet the criteria for substance use disorder for a drug prescribed to taper substance use. And finally, in a controlled environment. So again, going back to when I mentioned in sustained remission, that someone is able to maintain abstinence or refrain from use otherwise without the help of the more invasive treatment modalities such as inpatient. So in a controlled environment means that the person is able to maintain sobriety or abstain from substance use, but only in a controlled environment. So only if they're in a hospital, only if they're in a residential treatment program where they're not living independently and they can only, again, refrain from using in that environment. So next, I'd like to take some time to talk about substance-induced disorders. And this one can be a bit tricky because a substance use disorder can be comorbid with any diagnosis in the DSM. And so it's important to be able to note if if you're looking at comorbidity versus if you're looking at something that's only substance induced. So for example, someone can have a substance use disorder, let's say opioid dependence. Someone can have that and also have generalized anxiety disorder, or someone can have generalized anxiety disorder that is caused by opioid use. So in that case, it wouldn't be comorbid or co-occurring. It would be the opioid use disorder is causing the anxiety disorder versus someone who has a co-occurring anxiety disorder with opioid use disorder. So with substance-induced disorders, it is caused by the effects of the substance use. And the tricky part about this is that a lot of symptoms of intoxication and withdrawal also resemble the symptoms of mood and anxiety disorder. Therefore, because there's this overlap in symptoms, there's the overlap in consequences. So whether someone is experiencing mood-related symptoms that are not attached to intoxication or withdrawal, someone who's experiencing those symptoms can still have the overlapping consequences. So for example, if someone is actively intoxicated or they're experiencing withdrawal and they're severely depressed as a result of this, they could still have suicide ideation because again, those symptoms resemble mood and anxiety disorders. And so while it's important to differentiate, they will look pretty similar. So for example, a common symptom of intoxication and withdrawal is irritability, depression, isolation, all of those things that you might see in someone who has a mood-related or anxiety disorder. And you would still treat those symptoms with the same attention as someone who has one of those mood-related or anxiety disorders because, again, the consequences overlap as well. And in order to diagnose another disorder concurrent with substance use, the criteria has to be met prior to substance use. And additionally, symptoms must persist for more than 4 weeks after cessation of substance use. So in order to diagnose someone with something that's concurrent with substance use, they have to have already met the criteria for that disorder before substance use came into the picture. And you would have to see you would have to see those symptoms for longer than 4 weeks after someone has stopped using substances, because that's about as long as it takes on average. Of course, there are exceptions, but on average, it takes about 4 weeks for you to not feel those effects of the substance if you stop using entirely. So that's why we look at 4 weeks. If we're still seeing those depressive symptoms, those anxiety related symptoms, and it's been 4 weeks since the last time you used, then we'll look at diagnosing this as concurrent. But if we didn't see those symptoms until the substance use came into play, then it's likely a substance-induced disorder. So next we're going to look at gambling disorders, and the most current version of the DSM defines gambling disorder as a persistent and recurrent problematic gambling behavior leading to clinically significant impairment or distress as indicated by an individual exhibiting at least 4 of the following occurring within a 12-month period. So here's the criteria for gambling disorder, and as you can see, there's 9 in total. And again, I'm not going to read all of these, but I do want to point out a few because they look a lot like the criteria for substance use. For example, needing to gamble with increasing amounts of money in order to achieve the desired excitement. That kind of looks a lot like tolerance in a substance use disorder. Or is restless or irritable when attempting to cut down or stop gambling. That I'm looking at the second criteria. Has made repeated unsuccessful efforts to control, cut back, or stop gambling. So again, even though gambling isn't considered a substance because it presents like a substance use disorder if you look at the criteria, that's why we typically include it in the substance use disorder section of the DSM. And treatment can look pretty similar. Now Now looking at the severity and specifiers for gambling disorder, and again, much like with substance use disorder, this just helps us understand where the individual is and contextualize this for the individual, and it gives us that nuance just to give us a better understanding of what's happening for that person. So as far as severity goes, gambling disorder is considered mild if 4 to 5 criteria are met. It's considered moderate if 6 to 7 criteria are met, and it's considered severe if 8 to 9 criteria are met. And as far as the specifiers go, it can be considered episodic. So for example, some people might describe it as gambling binges, right? And so maybe at a certain time of the month or every once in a while they meet the criteria for this in a way that happens sporadically, or it can be persistent where it happens for a prolonged period of time with really no pauses in between. It can also be considered in early remission when someone is early in their efforts to cease gambling, and it can be considered in sustained remission when someone has been able to cease gambling for a prolonged period of time. Now let's look at some differential diagnoses for gambling disorders. So firstly, we want to make sure or differentiate whether or not the individual is experiencing a manic episode, because in a manic episode, loss of judgment and excessive gambling may occur during a manic episode. Actually, excessive gambling is a big indicator for a manic episode, and so an additional diagnosis of gambling disorder should be given only if the gambling behavior is not better explained by the manic episode. So if you only see excessive gambling in this individual when they're in a manic episode, then it's likely contributed to a manic episode versus excessive gambling. And that can be a bit confusing because, again, one of the specifiers for gambling disorder is episodic, and manic episodes are episodic. However, mania will have other symptoms as well. And so again, the gambling disorder only applies if it's not better explained by that manic episode. And next is personality disorders. So problems with gambling can occur in individuals with certain personality disorders. And so if the criteria isn't met for a personality and a gambling disorder, both can be diagnosed concurrently. So someone can have a personality disorder, and if the gambling piece of that isn't better explained by the personality disorder alone, then you could diagnose them both concurrently. And there are other medical conditions. So some patients taking dopaminergic medications, like medications used to treat Parkinson's disease, may experience urges to gamble because it's impacting that part of the person's brain. And so if those symptoms dissipate when the medications are reduced in dosage, or if the person stops the medication completely, then diagnosing a gambling disorder wouldn't apply. So you want to be able to rule that out as well. So now we're going to very briefly discuss diagnostic and screening tools. And so please understand that this is nowhere near an exhaustive list of diagnostic and screening tools. In fact, I could probably do an entirely whole other presentation on its own that'll be longer than this one about all the diagnostic and screening tools that are out there. These are just the ones that you'll see or hear about most commonly. And so they have different purposes. And so I encourage you to, if you can find some time on your own, sort of look at and see what's out there. And so starting with ASAM, or the American Society of Addiction Medicine. So this particular diagnostic tool takes the severity of a person's substance use disorder and codes levels of treatment for that. So it is not only a diagnostic tool, but it also helps point to a level of care. So for example, if someone is presenting with a pretty severe substance use disorder, then the ASAM would indicate that this person whether or not this person needs inpatient treatment or partial hospitalization or hospitalization or things of that nature. Or it might say someone who is, say, more on the mild or moderate side of the substance use disorder, then it might code for them needing something like an intensive outpatient program or something like that. And so if you work in the world of substance use treatment, substance use disorder treatment, you will see ASAM come up. And the reason for that is insurance companies will not even consider a case for covering care for substance use treatment if you don't have the specific ASAM criteria already outlined in this client's file and the treatment recommendations based on that. So insurance companies very much look for the ASAM criteria. And next is the CAGE questionnaire. It is a very brief questionnaire, about 4 or 5 questions, and this is used as more of a feeler. So if you ask a client these questions very briefly and they have a high indication with these criteria, then you can, typically you would go on to do a more in-depth screening tool to better understand what's going on there or assess further. So again, the CAGE questionnaire is just more of a feeler, and the CAGE acronym stands for Cutting Down, Annoyance, Guilty Feeling, Eye Opener. So the cutting down piece speaks to, you might ask the question might be related to what efforts, if any, has the client made to cut down their use, and if those efforts have been successful. The annoyance piece speaks to asking the client questions in the realm of if they become annoyed when people bring up their substance use or talk about their substance use or otherwise confront them about their substance use. Then the G in the CAGE acronym stands for a guilty feeling. So either guilt before or after using, or guilt when your use is brought up. And then next would be the eye opener. So then that would be the E in the CAGE acronym. And so the eye openers mean like if you've missed out on anything significant or experienced any consequences of substance use. So for example, if you missed your if someone missed their daughter's ballet recital because they were intoxicated, so that would be considered an eye opener. And so again, very brief questions, and they're yes or no questions. They don't go very in depth because the CAGE questionnaire is more of a feeler than anything. If they say yes for most of these, then you would move on to assess further, and that could be done with the diagnostic screening or just looking straight at the DSM to look more in depth. And then next we have our addiction severity index. And so what's interesting are the ASI. So what's interesting about ASIs is that people can be court ordered to get ASIs. So for example, if someone gets a DUI or something like that, or say someone at school who's a college student, maybe they're caught smoking weed in their dorm, like they can be ordered to complete an ASI as part of I won't say punishment, but maybe as part of the consequences. Or so people can come to you for an ASI screening without coming to you for substance use treatment. And it's actually fairly common if someone does come to you to complete an ASI for them, that you would actually refer them to someone else for their treatment. And so the ASI actually works in conjunction with the ASAM. The ASI uses a lot of ASAM criteria to look at, again, severity of use and helps you make recommendations for treatment. So ASI isn't necessarily a treatment tool, but it can be. And then finally, we have the drug abuse screen test, or the DAST-10, and the 10 just means that that's the most current version out there. So these assessments are get new additions all the time, and so the number gets higher the more. It's very similar to the process of the DSM, right? So now we're on our 5th revised edition, and so screenings, they update fairly often just to keep up with the culture around whatever it's screening for. So again, the 10th edition of the DAST-10, or the DAST-10, is what's out now, and it just looks at specifically drug abuse or substance abuse. And again, like I said, this is by no means an exhaustive list, but it just helps support these screening tools and diagnostic tools, just help form a better understanding of what substance use or abuse looks like in any given client, and then also helps to make treatment recommendations or gives you an idea of what treatment someone might need. So here are some things to consider for the future in the context of substance use disorders. So things that could potentially show up in the DSM in the next edition of it. So starting with technology. So there's a lot of research that has come out and is still coming out about how technology dependence or technology use parallels with substance use or gambling gambling disorders. And so you might have someone that um, talks about technology or presents with struggles with technology in the same way that someone might present with substance use disorder. And so, although that's not yet indicated in the DSM, you might want to consider incorporating some of those treatment modalities for substance use disorders for those with technology who have a problem or have problematic, use of technology. And then the next thing we want to consider for the future is substance use as a social issue. And so something this might impact is the social criteria for substance use. And so again, there's a lot of research coming out about how the more that the general public is informed about substance use and the social impacts, because substance use deeply impacts communities. And so what that means for the treatment of the individual with the substance use problem, and how you might incorporate social support with someone who is struggling with substance use. So just again, something to consider. And remember, like, as more revised versions of the DSM come out, as things have been shifted to be looked at with a more social lens, the criteria has also shifted with that as well. And the same could be true for substance use disorders in the future. All right, that concludes this section where we talked about substance use disorders. And as always, if you have any questions, feel free to reach out to either Amanda or myself, or we'll see you either in class or at the next drop-in session.